Okay, it's the bottom of the hour, so we'll get started. Welcome, everyone. My name is Marcia Spoto, and I'll be conducting the interview today with our guest, Craig Johnson. And I'd like to just start with a brief bio. So Craig is currently a member of the board of directors of the American Physical Therapy Association and has served in many leadership roles in the APTA, and in particular, the private practice section of the APTA. He's, of course, a physical therapist. He also has an MBA. He has over 40 years of experience in clinical care, practice ownership and management, and independent therapy practices. He has previously served as Chief Operating Officer of Therapy Partners, or TPI. And TPI provides support services to 28 member practices with 55 locations in their network in Minnesota and Wisconsin. Therapy Partners is a unique member service organization in the physical therapy industry, which contracts with third-party payers. TPI was one of the first organizations to establish a value-based payment contract and delivery model in 2009 with a local state-based payer. Craig has led other provider groups and payer pilots in many regions of the country using patient outcomes and care management to demonstrate the value of therapy services. As part of such pilots, he has analyzed claims data of payers, including workers' comp, parsing the data into discrete episodes, measuring upstream, downstream, and direct therapy costs, and identifying cost drivers in effective providers. Craig is a frequent speaker at APTA conferences on innovative models of care delivery. And I could only add that I personally very much appreciate Craig's contributions and leadership in the physical therapy profession, and in musculoskeletal management generally, and I value our friendship. Craig, welcome.
Thank you, Marcia. I'm glad to be here.
Yeah, so I'm going to start with kind of if you can just elaborate a little bit more on your background. And in other words, how did you arrive, kind of on the business side of practice and in leadership roles in the profession, and maybe start with what you came first, your MBA or your physical therapy education.
Yeah, no, sure. And Marcia, it is thank you for asking me to do this. I value our friendship. We learn a lot from each other. So it's just great to work with you on this. And I do want to give a disclaimer at the start here. I wear hats within the profession, and I just want to make sure you all know that what I'm saying are my opinions and my views, and I'm not representing the APTA or Therapy Partners per se. So, but just to fill in maybe some of the gaps, I actually had 2 times where I was owning practices prior to joining Therapy Partners. Therapy Partners happened to start in 1999 by 6 practices, mainly in the metro area of Minnesota, so the Twin Cities. And they wanted to try to do better with payment. And they thought by banding together, they would be allowed to do that. They also wanted to have economies of scale. So, all the back office services, which provides nothing but cost to you. I mean, you have to do all the billing and claims and working the claims and all that kind of stuff. So there's really no value to the practice. They wanted to share those costs and get better economies of scale, so it would help improve their profitability. I later got my MBA after I'd owned my first practice, because about that time, a lot of the national PT companies were starting to gobble up small practices, and they knocked on our door, and I was young enough where I couldn't retire, and I needed to work. Plus, I wanted to contribute, if that was going to be my new working environment, contribute to that. So I thought I should probably get my MBA and move out of the practice space and more into the business side. So that's really what prompted my MBA. And I did that 20 years after graduating from PT school. So it was kind of a tough reentry. But yeah, Therapy Partners is a very unique organization. I came to it in 2008. I knew about the organization for many years, and actually our practices competed with some of the practices in that network. But I gained a lot of respect for Therapy Partners, and particularly the people that they were able to attract high quality practices that really were patient-centered focused. And so they did things right. Eventually, I merged my practice into another practice that was a member of Therapy Partners, and that's how I came to Therapy Partners in 2008. And one of the things that they were doing back then, where I had a significant hand in leading, and that was our efforts to measure quality. We firmly believe at Therapy Partners, and I believe this too, that we need to focus on the quality of the care that we provide, and that we should always be advocating and trying to get payment that's impacted by that quality. So the better our quality, the better our payment should be. That to me is part of the value equation. And so we were just collecting outcomes data in our network, and I led that effort. And it's not an easy thing to do, which we found. These practices, they are independent, and we don't have any, Therapy Partners didn't have any ownership in them. So it's a little bit of herding cats, but we, I think, figured out how to really have our providers, the outcomes that they're collecting, really reflect truly what's happening to the patient. We steered away from steering the patient to a certain result. We really wanted to capture the improvement. And when there's not improvement, it's, you all know that it's not going to happen all the time. So we just wanted to make sure it was accurate. And many times, if you do happen to use an outcome measure, and if you don't pay attention to it, if it does not factor into your clinical decision making, your results are probably not going to show really what the patients are getting out of your care. And we learned that pretty quickly. So that's a big impact, or big impact I tried to have on Therapy Partners. Other roles that I played there, I was their compliance officer. I worked with the team that did contract negotiations with the payers, because all the provider practices, that is, all practices, they get access to the contracts that Therapy Partners have by being in our network and following certain standards and rules and so forth. And so it's really a good business model for independents, particularly in the state of Minnesota, where it's a fairly mature healthcare market, a lot of large health systems involved. Even though people in Minnesota are generally nice, it's not a really a nice place for independent practices to be, because things are so skewed towards the large health systems. But we have really been able to establish a strong, positive presence with the health plans. We have a good reputation with them. They really, I think, respect what we're trying to do. And we've been able to do well by our contracts. And part of that has been based on the strong relationships we've had, the positive relationships we've had, our reputation within the provider community for therapy.
All right, great. Can you explain a little bit more about, what an MSO is, what a management service organization is, and also what the independent practice might have to give up to be part of that network?
Sure. Yeah, so a management services organization is, you might even think of it in a different title or term, where it's a shared services organization. So largely what we do is we share services. We require that everybody be on the same EMR platform, that everybody collect outcomes and the same outcomes that we all are collecting for the practices. We credential them. So we credential all the providers. And we are all in the same compliance program and HIPAA compliance. We send claims out under the therapy partner's name and TIN.
Okay.
And so it's a fairly tight network, different from an independent practice association or an IPA,
Okay.
where everybody's generally, contract is held by the organization, but all the individual practices are billing under their own tax ID, so under
Okay.
their own TIN.
Okay.
And that's probably the biggest difference, and
Okay.
why I think it's one, successful, and two, hard to replicate, because you're giving up something, right? So
Yeah. Yeah.
when the group first formed, that was the hardest thing for them to give up.
Mhm.
Because a certain amount of value of your practice is in those contracts, right? That's your revenue stream. So they had to give up their revenue stream and put those contracts in the name of therapy partners. Well, when they formed, they all equally had ownership in that entity of therapy partners. But that's not the case now. But what I think has, even though that's been, you have to give that up and you have to be on the same platform. So if you're on one platform for your EMR or outcomes, you've got to convert to something else. But with those hurdles, we have grown over the years. I mean, when I joined in 2008, we had 12, well, actually not 12. We had 8 practice owners and about, I think it was about 16 locations.
Oh.
So it's grown since 2008 and continues to grow. And people are able to get over those hurdles. Generally, high level, we say that by being a member of Therapy Partners, you are going to make 80% of your own decisions. We don't do any hiring and firing for you. We don't do any personnel manual. We don't provide benefits for your staff or anything like that. So you're going to control about 80%, 20% you have to give up. And that means, you can't decide which EMR you're going to be on. You're going to be on our EMR, which outcome, that sort of thing. So there is some giving up, but it continues to serve independence well and continues to grow.
All right. So from what I'm hearing, it's sort of safe conclusion that, sort of the key to get your reimbursement up as, a value-based provider was really in the outcomes and demonstrating your value and benchmarking. Is that fair to say too? And is there anything else you would add to that in terms of, how physical therapists could, perhaps, in your view, for that independent provider who isn't part of an MSO, what advice would you give to them to get their reimbursement up?
Yeah, I think a couple of strategies you can employ. And one strategy that we definitely have employed, you have to find something that gets you in their door, right? So our way of getting in the door, we have size, but not everybody has size. But we have also, we also say that just gets you in the door. Then you have to provide something of value that they want. And so it takes good negotiating skills, because many times payers, the position that they take, right? They want to generally pay less. They want you to adhere to certain policies and comply with those. They want to pay just for medically necessary care. You have to really, I think, understand their perspective when negotiating with them. And like I said at the outset, find a reason that they would want to talk to you. And many times an opening line can be used as, we provide care this way, we get everybody in within 24 hours. whatever your strong selling points are. And if you can tie that to, we can help you control costs, we can give you good outcomes. Would you be interested in talking to me? Just something that aligns you with what they're probably thinking about. And oftentimes we don't know what they're thinking about. And so it takes practice, but if you can get your foot in the door with things that you already do that you think align with what they're concerned about, then you can start to build some trust and have that relationship where you can begin to negotiate higher rates.
Yeah, no, great. Great. What about, so far we've been talking about everything on the payer side, but I'm sure that you also have to build relationships with the providers in your area, particularly PCPs. Can you talk a little bit about what you've done, in that realm to contribute to the success of your model?
Yeah. So most of the branding of therapy partners is more payer focused than provider focused. But I'll give you a couple of stories about how we've engaged with providers. The branding of the individual practice is more community-based and provider-focused. So in any geographical region, PCP or chiropractors will know about orthopedic sports or about progressive therapy in their community. And so they really work at those relationships. We actually have 3 practices that share space and collaborate with chiropractors for their clinic as well too. And those that have gone that route, I think that they wanted to, again, help decrease the cost, that fixed cost of having your space for one thing, but also I think have a more holistic approach to their care and be able to, if patients go in their door, the PT door, a lot of our PTs are very much musculoskeletal focused and aren't holistic in their approach to patients. That's just their comfort level. I'm not really saying that's what they should be, but that's really kind of the comfort level. And I think they're collaborating with chiropractors you generally have a more holistic approach to the patient. And so that's worked well. And that's a small group of the practices in our network. We did, unfortunately, it died with COVID, and then some people changed chairs within the PCP organization. But I think I mentioned our market is fairly mature in Minnesota, and a lot of large health systems. Well, it's true for the primary care. Not too many independent primary care practices, but there is a large one that interacts with many of our practices, and they actually have a total cost of care contract with some of the payers, and we wanted to help them in the musculoskeletal space by being conservative care providers, which they already used us, but we approached them to collaborate with them on collecting data and demonstrating that by using our clinics rather than surgical specialists right out of the gate, that they would save money. And it was a direct PT model as well too. So they might contact that PCP's office, and instead of going to the PCP first, they would go they would steer them right to physical therapy. It just got launched, and then COVID just changed everything. And then their CEO left, and so it hasn't been reinvigorated, unfortunately. But that's another way to similar to relationship with payers, with providers, same thing. What are your concerns? How can we work together to improve both of our practices? And that was our approach with that primary care clinic.
Yeah, no, that's interesting. And yeah, the changing leadership can always be a problem when you develop relationships. I am hearing a theme here about developing relationships and, of course, that's important. Yeah, so kind of moving to, this PT first model, direct to PT, now I'm kind of also, I think, going to your experience with the profession as a whole, but some observations are that because actually you're mentioning that, for example, physical therapists seem a little less likely to adopt the role of a holistic, provider. And I did a Facebook Live session a couple months ago that, kind of looked at that and looked at the differences between the two professions. And that is something that sometimes is, stands out. But another thing we hear is, and I'm a little reluctant to just say hearsay, but it's that, not all physical therapists are really necessarily excited about adopting the role of primary care provider, which really by default you are. If you're the first person that patient sees for your problem, you are,
Managed
really
service organization.
moving into that role. So can you comment about, how well you think physical therapists are prepared to take on this role, or how it's evolving based on your view?
Yeah, that's really I think a accurate observation and a good question. And here's where my opinions will probably differ from people within the field or organizations for that matter. But I really do think that quality and preparedness, quality of education, preparedness of the graduate, it's a doctored profession now, it's a doctor's degree, is very good and very high. I think there's some steps along the way right after you graduate and even during your training that you do where we kind of fall flat. And these students will go to practices where the mindset is, this knee patient came in and I treated their knee and now they're good and now they're gone and on to my next back patient or knee patient, whatever. So they're not really acting like doctors, not taking a holistic perspective and view, even though they're trained in school to think that way and operate that way. So they get into these modeling situations where it's not the case. So I think that's one stumbling block that is changing.
Mm-hmm.
Not everybody thinks like me. I think, I tried to practice holistically and others do, but not enough. So as critical mass starts to shift more towards that mindset, I think it will change definitely. Much of the care and there's payer data. I won't name the payer, but there's payer data around this too, that much of the care provided by physical therapists are in large health systems. Mm-hmm. And they definitely have policies and a culture of team-based care that many times doesn't require that. Mm-hmm. The independent provider can provide that, and so they don't go that extra effort to manage the whole health of that patient or to make sure that it's being managed by somebody, because they just rely on the other medical providers to do that. And so I think it's really a good position for independents to be in, to change the culture and the mindset of the profession. And PTs, I think, stumble and have more difficulty with it than chiropractors. But I think it's changing, and independent PTs can play a role. We need to embrace that with organizations like Therapy Partners or any other independent PT organization. We need to take that seriously and do that. One strong voice within the profession I heard him say that, we should be measuring blood pressure on our patients because, you don't know when you're having them do exercise in your clinic. If you don't know what their blood pressure is and if they have any problems, you're going to be at a higher risk than doing any kind of manipulation on that patient. So we need to know that as physical therapists, and we don't routinely do that. So a lot of growth that needs to take place, but I see it changing, and I really believe it will change over time.
Yeah, thanks. I think it's very aligned with my observations as well. There's a lot of cross currents, and and physical therapy is a certainly more diverse profession in terms of settings, practice settings, particularly in maybe areas of specialization. And I also want to be sure to acknowledge that I have a lot of colleagues in practice that are really embracing this wellness model more, and really starting to recognize that, you've got a patient with chronic pain and you're not addressing their sleep function or their nutrition, then you're negligent. But I think the profession is struggling with, how to fit that all into practice. But I agree, it's evolving. And so, and it's also evident that even as the professions of physical therapy and chiropractic are kind of aligning around this primary spine practitioner model, which of course, PSPN is really another organization that is really promoting this, there's certainly a history of a competitive environment between the two practices. How do you see that moving? The relationship between the two professions?
Yeah, I think that is also changing. I think back when I was a young independent practitioner, it was much more competitive. But even then, I had chiropractors who did refer some patients because they wanted to stick with spine care, and they had extremity patients, and so they wanted me to see those patients. But I think it's also a mindset of a finite patient base, which is not the case.
Yeah.
It's certainly not true for both chiropractors and PTs. I think when it comes to spine, a much higher percentage of patients go to their chiropractor before engaging with a medical provider, compared to PT. So with that mindset shifting to, really, we're not seeing enough patients. There are many more people that really would benefit from the care that we provide. That will, I think, make for a less competitive environment. Plus, just the whole notion of that you're espousing, primary spine care partners, the payers. I hear this from payers, and I think that it's something that when payers are using those words, that we as providers need to respond and listen and probably do something. I think that the whole notion of understanding that PT, chiropractic, I guess primary care PCP, those are the starting points that they want to see for their low back patients.
Yeah.
They haven't changed payment yet on that, but that's who they want to see. And so I think there's enough alignment where I can see the PT and chiropractic professions aligning even stronger, and in some markets and in some practices, to take care of payers' members in a more effective way.
Yeah. Thank you. I tend to agree with you, and I think of when your comment about a finite number of patients, I think about the president of the private practice section, Mike Horsfield, who always is really echoing the same comments that you did, that there are plenty of people out there with musculoskeletal conditions, and what we need to be doing is broadening our net and, getting more patients into the conservative, realm. So I think I'm gonna hold off here and see if, David, do you have comments before we just open up for questions, or can we
Yeah,
just
I'll do a quick review of PSPN, and then you can head into some questions. In the time being, folks, you can add in your questions in the chat on the right or in the Q&A. Either or is not a problem. So go ahead and get that started. All right, 1 second. All right, so the PSPN, very briefly, just in a couple of minutes, for those of you who may be new here, PSPN is a membership community platform that equips primary spine care practitioners. Our focus today has been PT, but that includes chiropractors and other frontline providers with the tools, resources to advance their reputation, skills, and career. And for those of you that are part of it, the PSPN includes a few components, one of which is a 3-hour spine pathway training workshop, as well as monthly group coaching and supplemental mini workshops, as well as a host of tools that we're constantly adding to. There's a screenshot of the workshop and some virtual grand rounds, which will be starting soon. Benefits, of course, all of what I've mentioned, but notably, we do donate $1 of each membership to World Spine Care, an organization that brings higher value spine care to underserved regions. So for the price of a coffee a month, sign up today and give the gift of spine care to underserved communities while advancing your own skills, reputation, and career. And that's the sign up link, which I'll drop in the chat. Over to you.
All right. So I can, open things up now to audience questions or panel, members of the panel. Questions for Craig.
Panelists, you can just unmute yourselves if you have a comment or question.
While they're waiting, I've got a question to start with. And, this is, again, a little bit more broad-based, but based on your experiences, Craig, as a thought leader in the profession, what is your general view of the current strengths and challenges that the profession is facing? And this is, more 1,000-foot view, but.
Yeah, I think the physical therapy profession is very strong and focused on growing and improving in the areas of education, research, and practice. We implemented for education in 2016, all of the physical therapy education institutions had to be providing doctor degree level of education. And there's quite a few of them around the country, about 260 PT programs. And then also on top of that, there is a postdoctoral specialty certification programs, which are supported. Many of those people who get specialty certification, they go through residency and fellowship training to achieve that as well too. APTA has a foundation, research foundation for physical therapy research that awarded over $1 million last year in research grant scholarships and fellowships to 30 researchers. And much of the research in the past decade, and maybe it's a little bit longer, Marcia, but you and I talked a lot about the research over the years, has been focused on health services research. Mm-hmm. And really identifying the total cost of care and the benefit of starting with a conservative provider generally lowers the cost of care for that condition. So a lot of the focus has been on health services research, which is really helpful, I think, for advancing what we want to do as providers. And we've moved, the profession has most certainly moved from back when I started, it was kind of coming off of kind of a passive modality type of approach to care. And it's now much more active and manually based than it was years ago. So,
Yeah.
but it still has challenges to deal with. And I mentioned the doctoring program as well. That really it prepared students to be successful in practice, but they also took on a lot of student debt. And then that's tied to payment, and payment isn't sufficient to the point where they can easily retire that debt. So that's an equation we have to solve as a profession and work on.
Yeah,
I think
I
that,
agree.
yeah. And then the payers, administrative burden that payers place on any provider. We need to find a way to solve that and relieve ourselves of that. And there's some things going on, by CMS and by some local payers in our state, but CMS looking at that administrative burden, particularly on the Medicare Advantage programs that are going on. And I think I don't know what the population of chiropractors and PTs look like in terms of providers for the future, but I think that we're probably both facing a little bit of a shortage, and we need to have more graduates and more people staying within. We don't have people leaving the profession. We want to have people stay in the profession. And a lot of the things I mentioned earlier about challenges are some of the reasons why they leave, but to meet the demand of the population, to keep them healthy.
I've been reading a lot about that too, about the demand, and there's some discrepancy in what that is, but from what I read, I definitely see that there's going to be a growing demand. So, and we do have a couple questions, and so I think Brendan's question was first, so I'll read it. And David, this includes you as well, but I love the emphasis on demonstrated value in care. For David, does PSPN have tools to help with outcomes tracking? And then for Craig, do you have suggestions on the best specific tools or starting places?
I'll briefly answer that. We do have a bunch of tools in our kitty, Brendan, but we're actually reworking them at the moment. And I guess with Craig's help and combining the minds of many, we will pitch on a few of those that'll be best practice. And that's a great suggestion for us to actually put out on the PSPN and give to you guys for your use in your practices. So thank you for that. We'll get with John and with Craig and Marsha, and we'll get that going.
Yeah. So Craig, then from your standpoint, what kind of tools, because the private practice section, for example, also, has a lot of nice tools, but what do you find most helpful for clinicians to practice in this value-based world?
Yeah. So, collecting outcomes data efficiently, and then automating that as much as possible is what you really want to do.
Okay.
You can go paper-based. It's time-consuming for patient and time-consuming for you as a provider. And then you don't have any risk profiling of the patient. Because, if you have a stack of 100 Oswestry scores and you have the patient name, and it's really, again, hard to learn and gain some knowledge from that. So if you don't have any kind of risk factors that inform you as to how they're why so-and-so might have progressed and why so-and-so might not have progressed, that's an important factor. And so there are systems out there that have incorporated that into their measuring. And I'll give you a couple of brand names that I'm familiar with. There's no endorsement of them, but Focus on Therapeutic Outcomes is one that has risk adjustment as part of their calculation on the patient's outcome. So they're able to compare apples to apples pretty closely, I would say. Another one I'm familiar with is KEET, KEET, and both of them are fully automated. Photo developed their own measures based on the oswestry, based on well-known and research validated tools and measures. Keat also uses similar measures, and I think theirs is actually the oswestry itself, but it's fully automated. So the patient can do it electronically, captures the data, goes into your database, organizes the data and brings all the individual patients' outcomes together. And so you can have a collected database for your practice, and you don't have to sift through all the individual patients. So if you can automate it, that's the best. And there are more tools out there than those two that I mentioned. I'm just more familiar with those.
Okay, thank you. Yeah, and I think that's a selling point even for your payer negotiations. Just even the fact that you're collecting them and looking at them is sometimes sufficient.
Yeah.
We have another question from Dan. Craig, can you share specific strategies that independent musculoskeletal practices can implement to negotiate higher reimbursement rates with payers while simultaneously showcasing the value of our services and experience?
Yeah, I think the basic value equation holds true. It's the quality as the numerator and the cost as the denominator. So, if you can collect, you have to collect quality data. You have to collect outcome measures. That to me is what I think for us, our quality measures are the outcomes we provide, and it has to be in a quantifiable presentation. So if you have to start from there. If you want to go down the value-based contracting pathway, you have to have some kind of outcome data. Then I think obviously they have the cost data, right? They have all the claims data. Your practice management system should have some of that for you as well too. And you can then, look at both of those data points, your quality data, your cost data, and, you can also then ultimately get down to a price point for them. For this benefit, you're paying me X, and my X is probably cheaper than other, particularly in the PT realm, other health system providers, because they're getting paid better in the health systems in there and the independent practices, and demonstrate that there's value there. When we were first successful with a value-based contract with a payer in Minnesota, that payer actually did want to measure quality. So you have to find those payers to contact that are going to be willing to look at that and want to. I call them enlightened payers. It's not only about the money for them. They want their members to, go to the right provider, get the best care, because they swore and they say their data shows them this, that, if they enter the right door for any condition, they generally are going to have a good outcome and at a lower cost than if they go in the wrong door. And so they find that valuable, but you've got to have your outcomes data with you to start to go down that value-based contracting pathway.
Yeah, thank you. Yeah, I would agree in getting payers to systematize the analysis and how that works in regard to payment. That's all, I think the challenge really. And but you've got a system that sounds like it's worked quite well. So other questions? Do any of the panel members want to unmute yourselves and have any questions? All right. Well, we're wrapping up on our presentation. I will stay on with Craig and David for a little bit, if anybody wants to, have a little bit more of a one-on-one discussion. But we really appreciate your attendance today. And we'll be back soon. So.
Thank you, everyone.